Hi, everyone, and welcome to the first session in our online virtual learning series, Foundations in Psychedelic Assisted Therapy for Social Workers. I am the program manager of the Columbia School of Social Work's Psychedelic Therapy Training Program. My name is Brooke Stott. I'm also a practicing clinical social worker, primarily focusing on trauma, attachment, and shame. I was part of the 2022 California Institute for Integral Studies certificate in psychedelic therapies and research. I also have completed the MAPS MDMA assisted therapy training, as well as various ketamine assisted therapy trainings. This learning series is brought to you again by the Psychedelic Therapy Training Program at Columbia University School of Social Work in partnership with the Penn School of Nursing. The goal of this program is to build a psychedelic assisted therapy certificate training program as part of select students' MSW curriculum, and then to share that curriculum with other MSW programs across the country at no cost to them in an effort to improve affordability and access to professional training in the field for social workers. And that will be expected to launch in the fall of 2024. In the meantime, we'll be working to offer electives and programming in the area of psychedelics and clinical social work. Along those lines, this learning series is not intended to be a comprehensive training program in psychedelic assisted therapy, but to initiate dialogue and start building foundational knowledge in the field of social work. Notably, for the first time, we have a specific pharmacological drug paired with a specific therapy model under review for approval by the FDA. As social workers make up the largest segment of mental health providers in the United States, it's critical that our clients have access to these emerging innovations in clinical practice. As a reminder, with the exception of ketamine, these therapies are not yet available outside of a research setting. We are bringing you this content with the anticipated FDA rescheduling of MDMA-assisted therapy for PTSD and psilocybin-assisted therapy for treatment-resistant depression and major depressive disorder in the coming years.
I just want to jump in and thank our generous funders, the Stephen and Alexandra Cohen Foundation and the Joe and Sandy Sandberg Foundation. And I also want to thank our collaborators, the University of Pennsylvania School of Nursing, who did a 10-part learning series last year that was enormously popular, targeting nurses, and we have built off of their model. And so we're very grateful for their leadership and collaboration.
Thanks, Heidi. I'd like to introduce our moderator for this evening. Natasha Cody is a second-year extended MSW student specializing in advanced generalist practice. She is a lead organizer of the Psychedelic Caucus at the School of Social Work. Her service prioritizes equity and justice in the field of psychedelics and social work, and she'll be introducing our presenter for this evening and moderating our Q&A.
Thank you so much, Brooke and Heidi, both of you. Yes, I'm Natasha Cote, and I just wanted to introduce Dr. Jeffrey Zabinsky. Dr. Jeffrey is a psychiatrist and medical educator at Columbia University Irvine Medical Center, where he specializes in medication management and psychotherapy for patients with treatment-resistant and medically complex psychiatric illnesses. With Dr. Joshua Berman, he has helped launch and expand the clinical programs for intranasal ketamine and IV ketamine with the intent to develop and implement psychedelic clinical services once FDA clearance is granted. Dr. Zabinsky's unique multidisciplinary background started with his undergraduate training in biomedical engineering at Case Western Reserve University, followed by an MSW at the Mandel School of Applied Social Sciences and a master's in bioethics. Following medical school, he completed adult psychiatric residency training at Johns Hopkins, where he was a chief resident in his final year. He then completed additional fellowship training in consultation liaison psychiatry, a specialty dedicated to understanding and integrating psychiatric care for the medically ill. Dr. Zabinski joined Columbia in 2020 at the height of the pandemic, working on the hospital consultation liaison psychiatry teaching service and serving as the liaison to neurology. Through teaching, clinical care, and research, Dr. Zabinski is dedicated to helping expand safe, evidence-based access to a broad array of novel treatments and getting those treatments to patients who need them the most. Here he is.
All right, thank you so much. I'm just delighted to be joining you all and to share this exciting and very, very important topic. All right, so, this is session 1, Psychedelics 101, as the sort of title was. I wanted to make sure that I gave you a very broad overview, focusing on things that are important medically, thinking about risks, benefits, and sort of where we stand in the overall course of research and what things are going to look like in the years to come. So, let's see. Here we are. Okay, so this was my very ambitious agenda. I started with these questions. So what are psychedelics? Why should we care? What do we need to know? And how can we learn more? And so I have these on the right, sort of roughly grouped to answer some of these questions. There's just so much information out there, and it's the proliferation of content can be really hard to digest, really hard to understand. What should I be listening to, and what's high quality, and that can just be really tough to navigate. So I'm hoping that I can help do a little bit of that through the course of this introduction. And in focusing some on the mechanisms and the research, give you that introduction as you move on into other aspects of the psychotherapy that is typically linked with the psychedelic treatments. I have no disclosures or conflicts of interest. So I entitled this A Brief Long History of Psychedelics because in some ways, the research and the things that are happening now are building on really thousands of years of traditions in indigenous and ceremonial use. The first wave of research in psychedelics really was in the 50s and 70s, applying the scientific method and really thinking about things in a more rigorous way. And this terminology of psychotomimetics, so medications or substances that can induce or mimic psychotic symptoms. Maybe that was a bit of a misnomer, and I can tell you a little more about why. The psychedelic term itself originated not until the late 1950s in a sort of interesting set of communications between Aldous Huxley and Humphrey Osmond. Aldous Huxley is the author, and Humphrey Osmond was a psychiatrist at the time. This combination of psyche and delos, Greek origin, with a meaning roughly translating to mind manifesting. I really like that sort of origin for that term. The research stopped. I mean, there were a lot of political, cultural reasons that happened at that time. And there was still plenty of interest, but it just didn't happen in the same way and really set things back decades relative to where we could potentially be had that not happened. There was this belief that there was no benefit, that there was this risk of abuse, and that it would be dangerous to have people ingesting psychedelic substances in any form. The second wave of research, though, really started in the 2000s and has built to what I would describe as almost a fever pitch in the past few years, with people initiating studies or proposing studies in such a broad array of psychiatric illnesses, and also with interest in not just those who are ill, but people who are well, and thinking about, is there something that we can do to take people to a place where they're really thriving in their everyday life, and instead of merely surviving. So I'm going to talk a little bit more about some of that research, but I'd like to talk about what are psychedelics, what are considered psychedelics. It's not something that really has a standard definition. Some people talk about synthetic versus natural substances, although based on some of the research and developments that have happened, I wonder if that is a distinction that will really hold. But I do think it's helpful to talk about classic psychedelics as having a similar mechanism of action. That mechanism is the 5-HT2A serotonin receptor agonist. And I'll talk about which of these has that mechanism. Agonist means that they are activating that receptor, the serotonin receptor, which may be familiar from the medications that you hear about all the time. Things like Prozac and Paxil are SSRIs, selective serotonin reuptake inhibitors. So those are medications that we already use that have an impact on what's happening with serotonin, although not just serotonin. They end up being pretty complex, as are these compounds. This is the primary mechanism that we think about. The questions I put here are, is ketamine a psychedelic? What about MDMA? And it sort of depends on who you ask. They at least are not a classic psychedelic in the sense that I'm describing with the serotonin receptor. Have different mechanisms of action, and I'll share a little bit more about both of those. I think that part of this is when you're imagining what you're going to want to do with as it relates to psychotherapy, what course you want to take through somebody's experiences, and the different components of that. Conceptualizing ketamine or MDMA as a psychedelic or as having something in common with a psychedelic experience is probably very helpful. And I have this image of the molecules here. I have a couple more that I'll show that might be a little more useful. It's kind of abstract to just see them like this. You see psilocybin, LSD, DMT, MDMA, and ketamine are also on this. And I'll show you how it compares to the serotonin molecule itself. Classical psychedelics, as I said, act primarily via that specific receptor, serotonin receptor, agonism meaning it acts. Produces these acute changes in mood, perception, and cognition. The thing that we know about without doing any particularly detailed research is that it changes perception. It's something that's sort of been in the public consciousness for a long time. And in those indigenous traditions for a very, very long time, these alterations of perception and cognition. It's really these changes in mood that, while known, had not been quantified or approached in a way that was as rigorous scientifically. And I think that's the thing that has been the subject of a decent amount of research, among other things, among other aspects of these acute changes. Patient experiences are also often felt to be meaningful or spiritually significant. I think often is maybe an underestimate. Almost always felt to be meaningful or spiritually significant. Classic psychedelics, like I said, include psilocybin, LSD, DMT. Psilocybin itself, so this is a naturally found compound in more than 200 species of fungi. We'll talk about mushrooms. That's why, it's because that's quite a lot of species of fungi. Psilocybin is metabolized in the liver to produce this, the active metabolite. So this is what actually has that effect and makes those changes as someone is acutely experiencing the substance. The onset is within 15 to 60 minutes, so less than an hour. And then the effect lasts 4 to 6 hours. This is sort of a preview of when you think of doing therapy or you think of being present with a patient through a particular experience. It's kind of a long time. It's longer than any of the currently available treatments that are out there. So we're talking about a completely new sort of paradigm of care. And so that's exciting, but also sort of gives us a hint of some of the logistical challenges that are ahead as far as widespread adoption and implementation. Again, I've put this mechanism everywhere because I would like you to remember it, just because I think knowing that serotonin is impacted is an important detail when you're really thinking about a takeaway from a medical standpoint. There are also many other effects. There's functional brain imaging and thinking about functional connectivity of different parts of the brain. I think in some ways makes sense from the psychological perspective when we talk about what is happening, the psychological effects that I'll get to. But I think, really even down to from an imaging standpoint, that is something that's been demonstrated. This is another picture of those molecules. I think it's nice to just see this in the comparison between the active metabolite there in the middle and serotonin. Quite similar. You see the little OH is changed in its position on the molecule, but really otherwise quite similar. MDMA is a little bit of a different story. So MDMA is more similar to an amphetamine molecule, which I have shown here, it's a synthetic amphetamine, synthetic meaning that it's not a naturally found compound. The primary mechanism is indirect serotonin receptor agonism. It's a little bit different, but still serotonin. And again, with any of these things, the mechanism of action, I'm sharing just one of many things that it does. And the biological mechanism isn't the only consideration for this. So I'll talk about that though. Patients experience things like euphoria, increased feelings of empathy towards others, and mild perceptual changes. Onset of effect, similar in that it's 20 to 60 minutes. The effects can last a bit longer. Again, some of this is just depends on the setting, the goals of the treatment session, and even the way that things are dosed. We have to keep in mind, all of these substances have half-lives, meaning they exist in the bloodstream and in the body in a particular form for only so long before they go away. And once they go away, there may be some downstream effects, there may be ongoing psychological effects. There's something to at least recognize is that these are long. These can be really long sessions. How do they work? This is what I'm talking about a little bit with these mechanisms. So, okay, so what? This is what they do. Does that actually do anything? I think the biological effect that's most commonly described is this neuroplasticity, which is also described with ketamine. What does it mean to induce neuroplasticity? Neuroplasticity as opposed to like a rigidity. You can imagine that there's a potential to make changes more quickly. Sometimes I've thought, wouldn't it be nice if the changes that occur in a long-term psychotherapeutic relationship over many years even could be accelerated in some way, maybe instead of a 5-year course or several months of a specific course of CBT for depression or CBT for insomnia, instead of something that had a very prescribed duration of time. So there's something that we could do to join an intensive therapy with something that induces this neuroplasticity to get these biological effects that then would accelerate some of those changes. I think that's a hope. Whether or not that's exactly what's happening, maybe a different story, but there's the sense of induced neuroplasticity from the medication. And it's also anti-inflammatory. Inflammation being linked to a number of different symptoms that people experience related to mood disorders and others. There are also psychological effects that I'm going to describe in more detail, but I think when I'm talking about things like a spiritual experience, where some people describe it as one of the most meaningful experiences of their life, to have a dose of psilocybin, for example. That is included in the psychological effects that can't be just predicted from what this is doing biologically. And I think it's important to recognize that it's more than just some molecule doing something. Which is more important is mostly a rhetorical question. It's like, there's not really a good answer to that. And I think it's hard to imagine something that has a biological effect, but not that psychological effect. And then the flip side of that being a psychological effect without the biological mechanism that I've talked about. We do have that. I mean, a course of long-term psychotherapy does have a psychological effect, and really actually has a biological effect, but in a sort of different way. And then clinical trials have pretty much universally included this intensive psychotherapy, which makes it hard to really pull apart those distinctions that are artificial in some level. So the psychological effects. This slide I've used with permission from Natalie Gukasian, a well-known psychedelic researcher who was kind enough to sort of talk through some of these things with me recently. So increasing insight about self and relationships, increases in personality trait of openness. So this is one of when you think of validated personality measurements, the big 5 personality traits, one of them is openness. And really, it's difficult to see much of a change in these enduring personality traits through someone's lifetime. They change, but not substantially. This is an instance where a personality trait, and in this case, openness, changes and increases, which is quite unique. Next is this increase in psychological flexibility, it's curiosity about the nature of mind, and an increased capacity for mindfulness. It's also this mystical or peak experience idea. Mystical experiences you can think of from many of these traditions that are, like I mentioned, from all corners of the world in ceremony and tradition, often touched upon this mystical experience that is something that is well known for patients that have been in these trials. So where do things stand with all of this research? So the phases of a clinical trial are really what are holding things to a specific timeline. You can see the clinical trial process. I've put this diagram there. There's tons and tons of these diagrams out there. I thought this one just illustrated it in a very succinct way. You have a preclinical phase 1, phase 2, phase 3. As you advance, you get to the point of approval. You see the little arrows down at the bottom there between phase 3 and FDA review. The very, very exciting thing about this timeline to approval is that, in fact, just within the last couple months, a phase 3 trial for MDMA-assisted psychotherapy for PTSD closed and completed with its last patients enrolled just within the last few months. And so it's moving to the point of FDA review. This confirms the safety and effectiveness of the drug, looks over the research, and there's a number of things that are part of this FDA review process, but the end result, hopefully, is that the drug is approved. If it's not approved, there would be things that needed to happen, including additional studies and feedback that would happen, so that it was safely and safely approved, and we had all of the information that we need to deliver really safe and effective care. There are strengths and challenges of this medical model, of this review process. You can think, well, why do we need to wait through all of this? What's happening with, it's a Schedule I substance, so what does that mean? Does that need to be reclassified? The answer is yes, but how does that process happen? Is it happening in parallel? How quickly will it happen? And what does that mean for rolling out these services? I think could be a very in-depth conversation in and of itself, because there's a lot of opportunity for advocacy, and questions around equity and justice, I think, arise in that sort of access and the idea of gatekeeping. But I think that there are some good reasons to make sure that we're following closely to this, particularly when we're using this for medical illnesses, or rather medical, in that I'm including psychiatric illness. So when we're talking about psychiatric illnesses, I disproportionately treat patients who have really complex medical and psychiatric illness. And the idea of patients taking some of these substances unsupervised, I think risks a great deal of harm and time lost and great cost to the patient in every aspect of their lives. So I think in particular, that population I care so much about, I really want to make sure that that we're doing the right thing when it comes to this whole review process. Oh, and I also just included this side box in the corner. If you go to the clinicaltrials.gov website and just search psilocybin, you get more than 100 results. People are investigating psychedelics for so many indications. When we think of treatment-resistant depression, major depressive disorder without psychosis, these are things that are high on the list, that are likely to be happening sooner than later. And then when it comes to MDMA, thinking about that trial that I just mentioned, that's completing another phase 3 and hopefully entering review. I think there's just so many other indications, everything from smoking cessation to other substance use disorders to anorexia and other eating disorders. And just thinking about that broader context for if there's a psychiatric illness that we have had some hint might be related to this connectivity, then we should probably be doing the study and thinking about it very carefully. The other thing to mention about research that I think is a challenging factor from an ethical standpoint, as well as a drug development standpoint, is what do you do when it comes to the developing brain, children and adolescents who may have some of these conditions but maybe presenting in a very different way, in a different developmental stage. And there's really limited research on that currently. And I think for really good reason. This is a group of people who are quite vulnerable, and we want to make sure that we're being very, very careful. But I think from an ethical standpoint, if there is no current available treatment for a particular entity, I think thinking about trauma in particular and the medications that are available and the types of therapy that are available and their outcomes, it may be warranted at some point, and maybe even in the near future, to ensure that a subgroup, maybe it's older adolescents, maybe it's something more broad, needs to be thought through. But that's something that when it comes to a therapeutic perspective, psychotherapy, the psychotherapies utilized for those other age groups are very different. So just food for thought as we're going through the process to approval and what that might mean for the future. I've included this. It's a study from 2016 from Robin Harris, a very well-known psychedelics researcher. This was in the Lancet Psychiatry, it's an open label feasibility study. I thought this was a good one because it was open label. It's sort of towards the beginning of when things were really getting moving in a bigger way. And it's very clear to, as far as understanding the direct benefit. The follow-ups to this are out there as well. And you know, with more patients and more rigorous approaches. But I liked this because it showed just what that enthusiasm was all about. This one on the top left that you see, this QID score, it starts up in between that 15 to 20. That's in the severe symptom range. In this case, for treatment-resistant depression. So consistent with that, severe symptoms. And 1 week after this treatment is the patient has taken part in this treatment, you see a drop all the way down to between that 5 and 10 is the mild symptom range. Many patients dropped to the point where they were in remission. And those improvements sustained over the course of the subsequent weeks and months. That is truly remarkable. There is nothing else within the realm of psychiatry that really has this level of result that's currently available. Even with the many patients that I treat with intranasal S-ketamine, which is FDA approved, and I'll talk about more in a moment, and the IV ketamine treatments, there are things that can improve very quickly. In particular, the symptom that's associated with some treatment-resistant depression, that's suicidality, that can change very quickly. But the level of change and the sort of enduring effects in this particular example are quite remarkable. The upper right just shows individual patient trajectories using a different scale that sort of is consistent with the aggregated results from the QIDS score. The QIDS comes in several varieties. One is clinician administered, and then one is patient reported. The thing down at the bottom doesn't bear going into too much detail about, but just to say that these psychotherapy preparation, integration, kind of thinking through what this treatment is like really can be quite rigorous and involved. And I think thinking about this compared to what the standard of care is for psychotherapy and all of the times that patients end up on medications and aren't started with a therapist that is of a particular type of therapy that's a good match for patients, I think too often we're not giving the best standard of care in the sort of greater medical community. And this just really reinforces that with medication and psychotherapy combined, you get a much different result, much better result than if you were to do either one just in isolation for the right patients. Some patients don't require medications, of course, but for those patients who do require medication, that combination is so much more powerful. So I go from that sort of this enthusiasm about the research and this dramatic change in symptoms that patients are reporting to a service delivery case study. Essentially, what are we doing with ketamine? Ketamine has been available in some form or another since its development in the late 1970s as an anesthetic, as people were doing research on PCP for ways that you could actually use it in anesthesia. It's still commonly used in anesthesia and procedural sedation. But IV ketamine, oral ketamine, intranasal ketamine, notice ketamine, not S-ketamine, none of those are FDA approved, but are used off-label in many settings. off-label meaning they're not as tightly regulated. The dosing is not mandated by any specific governing body. And so it leads you out into a situation where people who may be prescribing are doing so with less than the ideal level of evidence when it comes to those formulations. Not that that shouldn't be done, but that it should be done particularly thoughtfully. Intranasal S-ketamine is one that's pretty exciting in that it was FDA approved in 2019. Although with all of these, there are complications related to costs, insurance coverage status, what patients have access and under what circumstances. And I think some of that can start to feel very frustrating very quickly, particularly from a justice and access perspective. With our patients, for example, the IV ketamine treatments are not typically covered by insurance. Can patients get out-of-network benefits? What does it mean if they haven't met their deductible and they're worried about where that money is going to come from? What happens if something is covered by insurance? How many treatments can they get? What happens if their insurance company declines to do the insurance authorization? These are very practical questions that come up all the time for our patients. Next is the role of psychotherapy for ketamine is largely not known. There are very few publications in the literature that talk about what type of psychotherapy, whether it needs to be a ketamine-assisted psychotherapy, a specific type that mirrors what's being done with psychedelics, or if we want to use the term psychedelics broadly to include ketamine, is it something that should be done in a similar way or in the same way? It's just not really known. There's some hints out there, and I think anecdotally, many people who do this work find that the patients that are improving often have that as part of their overall package of care. Also would add that in academic clinic, as compared to private clinics, as opposed to the VA system, can really vary widely about what's accessible and under what circumstances. So ketamine is for treatment-resistant depression, or rather the intranasal S-ketamine as it's currently approved. Diagnosis of depression, we do screening. There's the DSM criteria, which I'll flip up on the screen just for a moment, that helps with the diagnosis of depression for patients in treatment-resistant depression. Although ultimately, those are tools that we use as part of a broader formulation and evaluation. So a checklist alone won't get us to an accurate diagnosis because of so many things medically and psychologically that can mimic depressive symptoms. Treatment-resistant depression doesn't have a formal diagnosis, but especially as we're thinking forward about what would happen if psilocybin was approved for treatment-resistant depression, it's good to have this in mind a bit. Typically, patients have had at least 2 trials of antidepressants for adequate time and at therapeutic dose, which means different things for different antidepressants. My preference is that those 2 antidepressants come from different classes of medication. So if somebody's had Prozac, which is an SSRI, it's sometimes helpful, if appropriate, to see that they've also had a trial of something like Wellbutrin or something like Effexor, which is venlafaxine, an SNRI, different classes of medications. It's estimated that more than 2 million patients in the United States have treatment-resistant depression. Patients with this kind of subcategory of depressed patients have more medical comorbidities, double the hospitalization, 7 times the increase in suicide rate, and significantly longer hospital stays. So this is really a patient population that is reaching out for care and can be so frustrating to not be able to offer them definitive treatment. There are things that are out there, including other intervention treatments, and in particular, including ketamine, and it can make a really big difference for patients who have suffered for a long time. This is the major depressive disorder, DSM-5, just the quick flash to have it up there. Just a very well thought out set of criteria. But I think this in a vacuum as a checklist wouldn't really be sufficient. And as we all know, that evaluation is so important to understanding what a patient's going through. Ketamine works totally differently from what we've been talking about. It's an NMDA receptor antagonist instead of agonist, meaning that it's blocking this receptor. As I mentioned, used in anesthesia for a long time. It has been used recreationally by by people. And then it's also used in pain treatment as an infusion. Currently available in the formulations I mentioned before. And these are just images. So the one on the right, I think, is the most relevant because many people haven't seen it before. That's Spravato. That's the intranasal S-ketamine. And it comes in these cartridges and is sprayed it once in each nostril for several of those. And then the patient is monitored for 2 hours in a healthcare setting. These are some of the key pharmacodynamic targets for ketamine and S-ketamine. I thought it was good to just have this up here, just to show that when I say that it affects lots of different receptors, this is true for ketamine, but also the other psychedelic medications or psychedelic substances that I've mentioned. It's a lot. It's a little bit of all kinds of systems. And because of that, it can be complex when somebody asks, do we know how it works? And that doesn't account for all of the life experiences, the accumulated behaviors, the personality aspects, the entrenched maladaptive coping strategies that patients may have. It doesn't account for all of that. Monitoring for the use of these, of ketamine specifically for oral and IV use, there's not a required monitoring program, but for Spravato, the intranasal S-ketamine, there's a risk evaluation and mitigation strategy system. It may be that when MDMA-assisted psychotherapy for PTSD and when or if psilocybin is ultimately approved for use, you may have a REMS system, meaning each time a patient comes for a treatment day, there are some things that we have to track, including things like somnolence and dissociation, any adverse effects that the patient may experience. And so just thinking about this as a way to be very careful about what's being done and what we understand, given it's really different to give these substances to a few hundred people versus thousands upon thousands, or in that case, if we give it to everybody with treatment-resistant depression alone, perhaps as many as 2 million patients, that's really different. And you're going to see things that might be quite rare, but they're going to happen. And how can we be ready for that? How can we understand things better? A REMS system may be an appropriate answer to that, but we don't know how that's going to be yet. This is just how it works, the REMS system. And there has to be registration by the healthcare setting, either inpatient or outpatient, the pharmacy that's providing the medication, and then the patients have to enroll. Okay, so what does that mean as far as psychedelics? What do we need to do as far as screening? Why do we need to do it? And does our experience with ketamine have any lessons to offer in that? So I think the goal we would all have for the screening would be to reduce risk of adverse effects. And none of us want to do harm. And the idea that one of our patients could be potentially harmed by something, I think is that can increase your own distress as a practitioner. So we want to make sure that we minimize any risk. Studies usually have a medical and psychological evaluation prior to treatment, so a clinical interview, baseline labs, and EKG. There are medical reasons why that's important and that I'll talk about. We want to get collateral from family when possible, help complete the evaluation. A lot of this is just good practice for evaluation in an outpatient setting, certainly in an inpatient setting. And we're really looking for anything that would be would put that patient at higher risk, or other things that might be causing their symptoms. So often there are patients who have sleep apnea and have a lot of daytime sleepiness and symptoms that look an awful lot like major depressive disorder. And in fact, if you get them a sleep study and you get them in to have an evaluation, understand sleep apnea and a CPAP, they get better. And it can be really important not to miss things like that if we had too brief of an evaluation or weren't considering things like that. Some of this also depends on the overall medical complexity of the patient. The more medically complex the patient's history, the more likely I'm going to be to want to make sure that we're getting every detail, every we don't want to leave any stone unturned, let's say. The increased risk in treatment, so the group of patients who have an increased risk where treatment isn't offered in studies often includes cardiac conditions, high blood pressure, and arrhythmia. This is with classic psychedelics. Epilepsy, liver disease, as I mentioned, this is metabolized in the liver, meaning broken down in the liver. And so if you have liver disease and then that substance isn't going to be broken down as quickly, you may have a very different experience that may be dangerous. Most studies, patients can't be on an antidepressant, differs appreciably from patients who are getting ketamine treatment, who with Spravato, the intranasal esketamine, are required to be on an antidepressant. And then most studies, patients can't have a history of psychosis or mania. This idea of if a patient has a history of schizophrenia, has a history of psychosis, and you give a medication that has a history of being known as a psychotomimetic, and you induce a psychotic state that may persist, that would be really quite upsetting from a patient care standpoint, may require inpatient management, may require emergency medications. And then lastly, a patient who may be at very high acute risk of suicide. At that point, they probably need some other interventions. And whether that amounts to partial hospitalization programs or another kind of intermediate level of care, or maybe that actually means they need to be treated in an inpatient setting for safety. They probably would not be eligible for psychedelic treatment at this point. Perhaps in the future, we may learn more about this risk and be able to extend that. Preparation. So psychotherapy and the experience. This is true for ketamine as well as classic psychedelics and for MDMA as well. Establishing rapport, managing expectations, but really understanding what that is going to be like. What might come up? What are those perceptual changes? What have other patients experienced? What does it mean to have a meaningful or insightful experience in the midst of your treatment with people that are there to help support you? Currently, most of those studies are done with 2 therapists, and you don't want to be having this most meaningful experience of your life necessarily with people who are total strangers. So how can you prepare? How can you optimize this so that the patients are improving? Risks and adverse effects. For psilocybin and classic psychedelics, nausea and vomiting, headache, challenging psychological experiences. I think this is not necessarily something that we can ever hope to avoid completely. And in fact, there are times, as we know from long-term psychotherapy that we do with patients, where a challenging psychological experience can make a huge difference to overall course of care. But up to 25 to 50% of patients who are getting moderate to high doses of psychedelics may have these experiences. Rarely, urinary incontinence, hypertension, hypertensive emergency or urgency, which may require transfer to a hospital for management. Tachycardia, a behavioral emergency may occur. Anxiety often happens during the onset of the medication, again, within that first hour. And then periods of dysphoria or paranoia. For ketamine specifically, I would highlight that patients often have sedation and dissociation. The kind of behavioral emergencies that I've seen in our clinic that, again, sort of anticipate that care setting and some of those effects that patients may have when psychedelics reach broader use have included patients who have had an increase in their acute suicide risk, patients who've had prolonged dissociative symptoms that have resulted in very considerable distress, and then the risk for increases in anxiety or having a panic attack. So having medications, having someone present either directly or close by during monitoring to work through that with patients is really important. Now I'm going to just flash through some of these because they're really just kind of like bright and busy slides, but I just wanted to mention, as you know, there's a huge amount of psychedelics in popular media. I think it's helpful to think about who's the target audience, how's this interest in the attitudes about these going to evolve in time? Are diverse populations represented in all of this? The same is true for podcasts, and I've highlighted just a few here. How do you ensure that you have high quality information? A lot of podcasts, a lot of things that you can listen to are people just talking about personal experiences. There's an important role for personal experience in hearing from patients, hearing from people who have had treatments, but also those experiences are unique to an individual and their sort of accumulated life experiences. And to then have that represented as something that would be more universal can be pretty challenging sometimes. So having good high quality information from a variety of sources is helpful. There's also lots of books that are out there. Again, of varying quality and varying level of complexity. How to Change Your Mind, Michael Pollan's book, perhaps the most famous among them. And then other things that I think are relevant include whether or not they're up to date, because at this point, the evolution of the science is happening so quickly that could be a consideration, and seeing some of these books updated with recent research and expectations will be exciting. I have another sort of set of various questions and thoughts going through that I hope will kind of stimulate some of your imagination as you go on further in this series. Thinking about, are these medical treatments spiritual? Should everyone experience altered states such as these? For what patients is it just too high of a risk to experience? Under what circumstances should or could non-patients experience these, presuming that there was a legal avenue to do so? What do you make now of underground use, the role of community, tradition, and ceremony? How do we have respect and appreciation for the indigenous communities that have had some of the use for a much longer period of time? And how do we learn from the wisdom that has been generated in that? And then, do we have enough information at this point to do an adequate risk assessment? People who might seek novelty, who might seek treatment for reasons other than, for example, treatment-resistant illnesses, or other than the diagnoses that are approved initially. Under what circumstances would off-label use be warranted? So there are a lot of unanswered questions. Also, how to optimize treatment. And I think this is certainly a topic of conversation that will be elaborated upon going forward. Things like set and setting, room design. Should you listen to music? All of these things, patients who are coming to our ketamine program have so many questions about, and I counsel on different ways to really try and optimize treatment. But a lot of it is not rigorously or systematically studied. So a lot of these best practices are coming from just experience. And lastly, I wanted to highlight some of the ethics within psychedelics. So I think there are just so many opportunities for us to get into gray zones or really challenging situations. And it's important to think about them systematically. There was a paper by Smith and Applebaum within the last few months that talks about 4 areas of novel challenges within ethics and psychedelics: informed consent, underground use, commercialization, regulation, legalization. I'm not going to go through these in detail, but if you have questions about them, I'll be happy to talk about it, because I think this is one of the most fraught things. Once we have it, what do we do with it? How do we make sure that people are respected and protected? How to get training. There are so many different training courses that are out there. I've just put the bright and colorful sort of images for a few of them, not necessarily as an endorsement, but just as a recognition that psychedelics are not FDA approved for use. Training landscape is really complicated and sort of anticipates the approval. But what we can't precisely anticipate is when that approval happens, what will be some of the requirements and what will be the necessary credentials, and how do we make sure that the right people are able to access those credentials quickly. So that's why I think it's great for the opportunity for folks to engage in thinking about this in this setting, and then also going forward with the certificate program that will ultimately be offered through social work and probably many other places as these things evolve for specific uses. There's just a list of topics for the MAPS. Conferences, there's tons of conferences. If you really wanted to become more involved in the community of researchers and clinicians, these are some of the opportunities. They happen, some of them annually. There are many that are starting. And I think, again, with the sorting of What is something that's really going to have an impact on your practice? What is something that is that's inspired by things that might be slightly outside of the current development of the medical science? And I think those have a really important place in the overall community of psychedelics, but being mindful of which one you are accessing at a given time and how it's going to inform your practice, I think can be a helpful thing to think through before committing to these, as some of them are expensive to attend. There are also a growing number of professional organizations, such as the American Psychedelic Practitioners Association, the American Society of Ketamine Physicians, Psychotherapists, and Practitioners, Psychedelic Medicine Association. You can find, many of these that are kind of developing. I think it's yet to be seen which are the best or most effective communities that have developed, but in this sort of more formalized setting. All right, so I'm going to end there, just with this sort of, here's all the things that are out there. The way that I was trying to think through all of this as a first kind of trip into all of the ideas and issues that are out there. And I also wanted to just acknowledge Heidi Allen and Brooke Stott, and to thank Natasha for her kind introduction, and also just to acknowledge Natalie Bukassian, the psychedelic researcher that I mentioned before, just for her guidance in some of these ideas. So with that, I will finish and stop sharing my screen, and I look forward to the questions that you have.
Thank you so much, Dr. Zabinski. That was so informative. And I mean, you answered some of the questions that were coming in. And I really appreciated that, like the lens, cultural identity, and self-definition, and that like preparation process that you kind of touched on at the end. I want to start off with a question that came in around psilocybin. Microdosing has been growing in popularity, and I know I've heard a ton of positive anecdotes about its benefits. Does quantity of the psilocybin ingested matter? And what are what's the evidence say around microdosing?
Yeah, so thank you so much for that question. I think it's a really good one. It's one that I don't have a great answer to, but I'll tell you what I know. So microdosing is this idea that taking a very small amount of a particular psychedelic substance might have some therapeutic benefit. And I think that the evidence on this is really mixed. And, there's a lot of hope that you could have, some effect without having, for example, this, as we're talking about the psychedelic sessions as they stand in the research, these very long sessions that are very intensive with psychotherapy. If you buy that there are psychological effects that are essential in the sort of course of treatment, and that more powerful experience of those psychological effects is one of the critical pieces to these treatments, then I think you'll be more on the side of probably, if you have a patient who has an illness that you're really trying to manage specifically, that you want to get that full benefit in that setting. You want to make sure they have a macro dose. If perhaps there's a place for patients with milder illness, or for increasing the interval between dose sessions, I'll give an example from ketamine. So for patients who respond to the intranasal S-ketamine or IV ketamine, is there some lower dose of something? Could you give, there's a new medication called Auvelity that has a similar mechanism of action. Could you extend the intertreatment intervals? I wonder about that for some of the microdosing, but I think just where things stand now, it's too hard to really predict what that's going to bear out in the research, at least my read of it right now.
Yeah, it kind of like goes back to that setting. You're wanting that like larger dose, and you think that's going to be a benefit. It might be more. And then I know that like with a lot of the sort of microdosing antidotes, and maybe do the thing that you want it to do upon that intention you put into it. So thank you for answering that.
Well, I wanted to say just one other thing, just to that point, because I think it's a good point, is people will often say, well, what if it's placebo? What if taking a really tiny dose, it just gets metabolized and it goes straight out? Well, I really don't like the term placebo, because I think, what does that mean? That means that you're getting benefit from something. And whether that means that there's a psychotherapeutic benefit, I think sometimes, the way that the treatment sessions go for Spravato, for example, you come to this quiet, dark, comfortable place and we do this treatment. We're really wanting to make sure that we take care of you. We're talking to you before and after. We're making sure that things are prepared. We're making sure that you're really taking care of them, that this is a safe and comfortable space. That in and of itself is a great intervention, and that's a psychotherapeutic intervention. And so if you have a particular pill or a medication or something that you're taking, and you say, I'm taking this because it's going to help me get better. I'm focusing on myself. I want to make sure that I'm doing the right thing for me long-term. And if you're thinking that, and if you're developing that, and you're taking that on a regular basis, that may have some benefit. And I don't like calling it placebo as much as I like thinking of it as just another type of psychotherapy.
Yeah, if it works, it works. And that absolutely matters for sure. And then just in that kind of aspect of time, in the duration of the treatment, are there considerations for psychedelics that can achieve those similar benefits, maybe that take a lot less time in the clinical setting?
So essentially achieving benefits more quickly, that would be in comparison to, what was it you said?
I was just in comparison to psilocybin, I'm thinking DMT, some of the psychedelics that maybe are a lot quicker acting. I don't know what the research says about that.
Yeah, I think it's a helpful comment for two reasons. One is that one thing I didn't really highlight as much, because I was just thinking sort of classical psychedelics, broadly speaking, is psychedelic compounds are different. They have different profiles. They have different results, different experiences that people have. Likely when it comes down to it, they may have different risk profiles. Now, if they have the same or similar mechanism of action, those risk profiles will probably look relatively similar in the way that Prozac compared to Paxil, compared to Zoloft, compared to Lexapro, this broad range of substances that have similar mechanisms, but maybe a little bit of a different fingerprint. Whether something could be quicker or not, I really don't know that we have enough information that has been in these larger or higher fidelity studies to make a strong statement about that. I mean, the hope, though, would be that we can really optimize that to get the fastest benefit possible. Because again, if patients are really suffering, that's what we want. I think as practitioners, as just human beings, just to see people get better as quickly as possible in as safe a way as possible.
Absolutely. And then, time, it's all relative, and the amount of time it takes, as long as we're treating it and we're working through that healing, it's super important.
Reminds me of the perception of time in the course of that may be altered in the course of an experience with a session.
Yeah, maybe those 4 hours feel like 1 hour. Okay, so there's more questions. How long do the personality measures changes last? Is a question we got.
I think that's a good question. So, we think of personality traits as being more enduring traits, that if you measure them when you're 70 years old, you may see something quite similar to if you measure those personality traits when someone's 25 years old or so. So what does that mean if one of those traits has changed even slightly, or rather in a way that might be meaningful in the way that they interact with other people and in the rest of their life? So I think that if we buy the idea that personality traits are fairly enduring, that we may say that in fact these changes will likely be longer term. I don't know of research that has looked far enough out to really give us a sense of that. What I would be really interested in seeing is if you had a cohort of patients that had been in the first wave of psychedelic research in the kind of 50s to 70s range. If you had a cohort of patients there that you could then administer, if you had a before and after, and then could do a retest of some of those, that would give you a good sense of it. I just don't think enough time has passed for us to have a great answer to that.
So the next question is around ADHD. As MDMA operates similar to amphetamine, is it ever used or considered in treatments for ADHD?
I think it's a great idea. I'm not familiar with that literature, especially since I mostly treat patients with treatment-resistant depression, though I see other patients with PTSD, obsessive compulsive disorder, and some other things in the context of ketamine treatment. I'm just not familiar enough to say something more strongly about it. And I think from a mechanistic standpoint, it's very reasonable.
And that kind of goes into, I mean, similar to another question about MDMA for metastatic cancer or terminal illnesses, just in the end of life care. Yeah, so psychedelics in end of life care, especially for essentially compassionate use, is something that has happened to a greater degree than for some other conditions. And we know that there are all kinds of things that are done as far as interventions and treatments in that time period to try and affect a lot of things, a lot of psychological factors. MDMA and classical psychedelics have been used in that setting effectively and have had positive outcomes in studies. I think the other thing to add with that is, I think I'll just leave it there. There's positive results from studies, and I think it's a good potential use. Yeah, there's places that PTSD symptoms can arise. Both from a vast array of traumatic experiences. One that I have particular interest in is post-ICU. So patients who are admitted to the hospital with critical illness have as high as 50% of patients who survive an ICU stay have clinically significant PTSD symptoms. And currently there aren't any good interventions. The way that PTSD sort of presents, or those post-traumatic symptoms present, is a little different than what you might think of as sort of PTSD from a war setting or from an abuse setting. So that is another unanswered question, is what about MDMA for post-traumatic symptoms after an ICU stay? That's one that I have thought more about, let's say. Yeah, that makes me think about just the different ways trauma, shows up, and how there's growing research, but yet there's still so many avenues, right? Like I'm thinking about racial trauma, and like you were saying, ICU and first responder trauma as well, vicarious trauma, and what the future of psychedelic therapy looks like for that. And that kind of brings me to a question I had about kind of ethnic, cultural identity and its importance in that like healing process, as well as spiritual identity. Are there like any assessments in that screening process around like spiritual ethnic identity and self-definition to kind of like help the therapist gauge maybe other types of treatment models to bring in?
Yeah, not that I know of.
That is such a great question. I do want to say quickly, though, that we have a social worker coming to speak with us in 2 months who will be going way into that. Jennifer Jones, she's amazing. So, Jeff, you can, certainly take a shot at answering the question, but we think that is such a big question that deserves its own session. So we are having a whole session about the therapeutic process, and part of that is the relationship between the therapist and the patient, identity issues, and how you prepare people for the experience within those frameworks. So thank you for bringing that up. But Jeff, did you have anything you wanted to say about that?
No, just that it's an extremely important component of psychotherapy, period. And then let alone when you're having something that is as intensive an intervention as this, you really want to be extremely thoughtful. And I think that's, when we think of the composition of researchers, psychiatrists, and how well the composition of those professionals matches the patient population, that's something that gives me a sense of mission in what can we do to ensure that that we have a more representative group of people who are able to administer these treatments, to be there for patients, to be able to connect in ways that that others might not be able to. I mean, of course, there's always some flexibility with aspects of that. And so the first step is just really knowing where your gaps of knowledge are, knowing all of those pieces. So I'm really glad to hear that there's a talk that'll be coming on that. Because I definitely think that's not an area of my expertise enough to go into detail.
Yes, I'm so excited for that coming up. The next question, kind of related. Someone is wondering about how we honor Indigenous practices as clinicians.
Gosh,
And I'm going to jump in one more time with that, because that is actually what we hope will be the topic of January session. So January will be Indigenous practices. February, part of February will be this elements of psychedelic assisted therapy. But again, Jeff, I want you to, I just don't want anyone to get the sense that that's, that whatever you can say in these couple of minutes is the limits of what we are planning to cover in this learning series. So.
Sounds like people are ready. They're ready for all of this knowledge and information, and to integrate it into what will ultimately become their own excellent practices. So I'll defer a bit on that one, just to say that there is such a lengthy tradition out there in all kinds of different places and settings, and it would be really nice to see that honored and respected in a way that doesn't just reach the level of sort of cultural appropriation or something that would be really doing a disservice to that history.
Yes, most definitely. There's that distinction between a ceremonial practice and then like clinical practice. And that is an important distinction to make.
It is, but also it looks like some elements of that ceremony and tradition and like that there's meaning that's imbued in that may be important for the outcomes of patients who are getting treatment. I think makes it a kind of complicated question that exists in a space that isn't one that that physicians as a whole are as comfortable existing in. I think psychiatrists more than some others, but it's a difficult thing to sort of place in the overall set of interventions that we're doing. It's very different, very different.
Yeah, and I think, this psychedelic revival just calls to like that convergence of the spirit and science in a way that like have been very separate. And so like everything coming together right now, we're in this like interesting dance, and really excited to see how it plays out thoughtfully. Okay, some more questions since we have so many. I don't want to miss any.
I think one common question that I've seen, because you guys have been talking, I've been trying to eyeball it, is there's a lot of questions about counter indications. Like, are there certain populations, like people who have had an experience with psychosis, or people who are addicted to certain kinds of substances? Do you think that there at this point are kind of exclusion criteria?
I think there are sort of anticipated exclusion criteria. Now, I think it's a complicated question because the exclusion criteria is for studies. And so they're not even studying what would happen if we gave a patient who has a history of schizophrenia or a psychotic episode some of these substances. But we know from case studies, from historical sort of administration, from patients who may have a diagnosis that was unknown or not discovered in the process, that there can be sort of more challenging outcomes. I anticipate that psychosis is one. But even then, I would want to do a careful psychiatric evaluation and say, if a patient had one episode of psychosis, I would want to know under what circumstances, what was the nature of that psychosis, and does it speak to a broader illness that they have, or is this something that is more isolated? I think it ends up being a really complex question, but psychosis specifically is one I think needs to be very carefully considered. Mania and bipolar disorder, I think, is one that I feel, in the experience with ketamine, if you have a patient who's on a mood stabilizer, who is on an antipsychotic medication for their bipolar disorder and has been stable, and yet has treatment-resistant depression, should we treat with ketamine, esketamine? Should we consider interventions when they're available, like psilocybin, MDMA, et cetera? Maybe. I think that one may end up being a relative contraindication, or initially a contraindication until we have more information. Then the other part of that was this question about substance use disorders. And currently with ketamine and with esketamine, that is a contraindication or a relative contraindication. If somebody has not had active substance abuse in the last 6 months, is in treatment, or is lower risk for relapse, I would carefully consider treating that patient. But if a patient has active use, we would say, not right now. Here's the resources that you need to access first, and then come back to us, because maybe in the process of getting treatment for that use, you will see that your symptoms evolve, maybe improve. There are studies that have some really impressive results with psilocybin specifically for smoking cessation and with other substance abuse. So it may be that these are treatments for substance abuse ultimately. I really hope so, because we have a limited array of tools to do that now.
So one of the questions was about whether or not it's important to have the subjective experience, or, is this purely like something that the molecule is doing to your brain that's leading to these outcomes, or is there meaning making and the importance of meaning making? And I think that you might have mentioned it in a slide, but do you want to say anything more about that?
Sort of the biological as compared to the psychological effects. And then this sort of touches on some of the same kinds of things from the microdosing idea. And sort of, I think the way I also mentioned it was sort of pulling apart. If you could just have the biological or just have the psychological, what would that look like and what would that mean? I think that both are important, and that going forward, the way that the research has been done is in a way that reflects the importance that the medical community more broadly has sort of placed on the importance that has been placed on that in the research studies that have been done. So I think that the efforts to sort of take that part out are interesting, but I don't feel personally as optimistic. I'd like to see the results of studies once they're done, because that'll be the real answer.
There's a really interesting study happening at University of Wisconsin-Madison where they're giving in a randomized controlled trial study participants, is it propofol? Is that right? The amnesic drug
propofol.
That's used, for if you're having a surgery so that you don't wake up and remember the surgery. And to basically test that. So if people finish their experience and their medicine session, but they don't have any memory of it, do they have the same outcomes as people that are able to take the experience and the images and the sensations and tell a story around it? I'm very eager to see what they find. I think that will really contribute to the conversation.
Yeah, I think the other question is, what do we know about what propofol does when you have an infusion? And might that complicate at all the results of that study? I think it's a better design than some alternatives, let's say.
Another question that came up is, what about the long-term effects? Do we know anything about long-term adverse reactions?
Well, I think that's something that, again, particularly in a way that's rigorously studied, it would be hard to answer that question. However, as it stands with the, for example, the indigenous traditions that have been using for thousands of years, consistently through the lifespan, maybe it's a ceremony that happens only once in someone's lifetime. Maybe it's something that happens more than once or more frequent use. And I think from that, we haven't seen that there have been adverse effects sufficient to for those to sort of cease and for people to have linked those. But I don't know that we have a clear answer yet.
That kind of goes to a question that came in. What's the rare adverse reaction? Common wisdom is that it's so safe that there's no risk of adverse reactions and that even negative psychological experiences are integrated as positive. Is this really so?
I think that's one of my biggest concerns when it comes to the rapid adoption of these substances in kind of popular culture. I think that there are a few groups of people that I think about. One is a very medical sort of, this is a person who has a syndrome of major depressive disorder with a set of signs and symptoms that exist over an episode, a specific period of time. And they get better with particular kinds of treatment. But that's one set. I know very clearly that this person has a specific kind of illness that I think of as a little bit more of a biological kind of thing, although not exclusively. But let's say that there's there's a dozen things that we call depression, and what we're really doing is trying to figure out which subtype of depression we need to be addressing with a specific treatment or medication. And again, it doesn't always include the medication, but when it does, how do we select one? I think for that population, I am worried about some of these bigger risks. People who have medical complexity, hypertension, may have a dangerous arrhythmia, who might have a psychotic experience that persists beyond the period of time for the session. Who's going to take care of them? How is that going to be done? Will you stay with them all day and all night? Will you transfer them to an emergency department? And I think if we can reduce the risk that something like that is going to happen, then we should. And we have to think carefully about dosing in that setting and be very thoughtful about the preparation that we do. There's this group of people that's the more medical. There's one that's in between that maybe they don't have as severe of an illness. Maybe they don't have a lot of medical comorbidities. We may not really need to do much screening for that group of patients. And then there's another group of patients that are probably fine and that could take doses and use in a more recreational sense without a significant risk of harm. The thing is, we don't know how to differentiate very easily at this point. We have, that's why I think it's important that we end up having some kind of evaluation, that we make sure that we're thoughtful about that. But what that evaluation will ultimately look like, for these different groups and how can we separate them out, that's the thing that we're going to try and develop. And I think a lot of that will ultimately happen when it's in clinical practice.
Next question is really great. As an MSW, what do you think social workers can uniquely bring to psychedelic therapy?
I love this question. I think this is like the best question. So I think that social workers are so well positioned to do this amazing work because if you have patients who are coming and requiring this really thoughtful, sort of sensitive, psychological sort of care in the midst of a session, in preparation, in integration, who better to think through in a comprehensive way all of the factors that have influenced that person's experience in their life, the resources that they have, what aspects of their identity may be impacting what they're experiencing. I just think that that's really at the heart of the mission of social workers. And so thinking about, a space that could include a diverse array of professionals, but hopefully with social workers in a prominent role, just to really be doing this important work directly with these patients who are in such great need. I just think that that's where it is to me. It's just in really direct work with patients that extends so far beyond just that one treatment session, but in establishing good rapport with a patient, in establishing that relationship that's so important. Who better than social workers, I think.
I think that's a perfect place to end. That was a brilliant response. We are so excited to have social workers in this profession. And I think we can all agree that we really have something special to offer. And that without us, there will be extremely significant access barriers for people who need these important therapies. So thank you so much, Jeff. Thank you so much, Natasha. Natasha, I'm going to want you to moderate every session from here on. That was amazing. And Jeff, you did just such a wonderful job. We really appreciate the perspective you brought as both a psychiatrist and a social worker. I think that's a really unique pairing of degrees, and you're a perfect representation of the value of bringing those two educations together. Thank you.